Thank you, Audrey. I want to thank the OC Foundation for inviting me to speak this evening. I took my first class here at OC in 1995, and walking around campus today, it was really unrecognizable. It's great to see this beautiful auditorium, state-of-the-art technology. It's really great to see the campus flourishing. Before I begin today, I want to disclose that my presentation today is my own and does not represent the views or opinions of my employer, PATH, or any other institutions presented in my talk today. I'm going to start by defining what global health is and why it is important, and then using cervical cancer as an example, I will highlight some of the challenges that we face in the world to promote health, and then some of the innovative solutions that we have created to overcome these problems. So what is global health? Global health is collaborative, transnational research and action for promoting health for all. Based on the definition, there are 3 pillars of global health. Global health is concerned with equity, it involves multiple nations, and it is collaborative. I'm going to expand a little more about this in the next few slides. Global health is focused on promoting equity in the health of populations around the world. Let me give you a few examples. The lifetime risk for a woman dying from pregnancy complications or childbirth in Canada is 1 in 11,000. In Niger, a country in Africa, it is 1 in 7. Life expectancy at birth varies by 50% depending on where you're born. If you're born in the developed world, you can expect to live about 80 years or more. If you're born in the developing world, your life expectancy is half of that, about 40 years. So why do we see these differences in disease burden, access, and utilization of health services? And why does disease disproportionately affect one group, such as women and children? Is it biology? Is it geography? And how can we minimize these inequalities? We are dealing with problems on a global scale. Disease knows no boundaries. A pathogen can travel from a remote village to a major city around the world in as little as 36 hours. A few examples of recent pandemics that we have experienced are H1N1 influenza in 2009, Zika virus in 2016, and in 2017 and 18, Ebola. And we're not just concerned with infectious agents moving around the world. Western lifestyles are spreading globally. Changes in diet, lack of physical exercise, heavy reliance on cars, smoking, stress, has all led to an increase in cancer, diabetes, and cardiovascular diseases worldwide. So these are issues that are affecting everyone. Addressing inequalities in health status requires collaboration on a global scale. The eradication of smallpox in 1980 through immunization is one of global health's greatest success story. It was a coordinated and collaborative effort across nations with a unifying vision led by the World Health Organization. Another example is the HIV/AIDS epidemic. In 2000, it was raging out of control, and in countries in Southern Africa, life expectancy was falling rapidly. Billions of dollars were invested in HIV and AIDS research that resulted in better and safer drugs that provided life-saving treatment while also massively reducing transmission. So today, why should we care about global health? Bottom line, we care because it saves lives and offers protection from disease. We cannot protect our borders and the health of our citizens without addressing diseases elsewhere in the world. Take our military, for example. They're often deployed to other countries where they're exposed to diseases. So if we can help detect and control outbreaks at their source and assist other countries to increase their ability to prevent, detect, and respond to health threats on their own, it ultimately benefits us should we need to deal with these diseases on our soil in the future. Saving lives promotes food security, economic development, and political stability worldwide, which in turn impacts our trade with other countries. For example, much of our food and produce comes from outside the United States. In 2016, 53% of fruit was imported. So the people who are growing and harvesting this food, if they're unable to do so because of their health, then we might experience a drop in supply or even a food shortage. Global health creates jobs. The US has been instrumental in developing a variety of global health interventions. As a result, we have created jobs in research and development across all disciplines in our country. This gives us a competitive edge worldwide for our innovative healthcare products and services. And lastly, it's about expanding our knowledge. Have any of you heard of kangaroo care? Great. For those of you who haven't, kangaroo care is a method of holding a baby that involves skin-to-skin contact. The baby who is naked, except for a diaper, is often placed naked in an upright position against the parent's bare chest. This is mostly for preterm babies, but encouraged for all babies, as research has shown that skin-to-skin holding has been shown to stabilize heart and respiratory rates, improve oxygen saturation, help baby regulate their body temperature, and conserve their calories. Kangaroo care was pioneered in Bogota, Colombia in the late 1970s, where the death rate for premature infants was almost 70%. Babies were dying of infections, respiratory problems, and simply due to lack of attention. Research has found that mothers who held their babies close to their bodies for prolonged periods of time not only survived, but thrived. This simple solution has been adopted worldwide and is practiced in our very own delivery rooms each and every day. Now I'm going to show you a short video that summarizes why we should care about global health. This video illustrates why we invest in vaccines. The video was created by Gavi, the Global Vaccine Alliance, which is an international organization created in 2000 to bring together public and private sectors with the goal of equal access to new and underused vaccines, particularly for children in poorer countries.
It's hard to get started in life, whoever you are. One highly effective way of helping everyone, rich or poor, to a better start comes in a little bottle. The impact of vaccination is greater than we ever thought.
I get sick less often, so I can go to school. My scores are higher in languages, maths, and in IQ tests.
I can finish my education and get a better start in life.
And while I'm at school, my parents, my family can do other things.
And since they don't have to spend money on my care, they can save it for better food, new clothes,
or a nicer home.
my vaccination also helps protect other people in my community.
If I don't get sick, then I can't pass it on. Because I've done better at school, I have more opportunities.
Earning money means I can help my family. As I work longer, I can also save for my future.
I can think about starting my own family and helping to build a community.
A healthier community is more stable. It's a place people want to live in rather than escape from.
People want to visit us and maybe even move here too.
Many others want to invest and to trade with us. That little bottle has consequences none of us could have guessed at.
Immunization has helped millions of children to a healthier start in life.
And better health is helping build a secure future
For people
everywhere.
I'm now going to switch gears and talk about cervical cancer, an area that I've been working in for the past 7 years at PATH. Globally, cervical cancer is the third leading cancer and cause of cancer-related mortality in women. This map shows the incidence of cervical cancer worldwide. We can clearly see that there's a big difference in cervical cancer incidence. The darker the blue means more disease, and we can see that there is a higher incidence of cervical cancer in developing countries. About 85% of cervical cancer occurs in these blue areas, which are developing countries. About 20 years ago, it was discovered that cervical cancer was caused by a sexually transmitted virus, the human papilloma virus, known as HPV for short. HPV infections are very common, and many clear in about 1 to 2 years. But there are certain strains, such as 16 and 18, which account for 70% of cervical cancer. Once exposed to the HPV virus, progression of disease can take 10 to 15 years. Hence, prevention is key. When we look at how to prevent cervical cancers, there are 2 key strategies. First, vaccines. HPV vaccines mainly provide protection against strains 16 and 18, and only if administered to preteens 11 to 12 years of age before they ever become sexually active. Secondary prevention by cervical screening is needed to identify precancerous lesions caused by other HPV strains among women who are already sexually active and/or did not receive the HPV vaccine. So let's first take a look at primary prevention via HPV vaccines. HPV vaccines were first introduced and made available in 2006. It's the only vaccine that prevents against cancer. It is very safe and effective. Like I said before, it protects against 70% of cervical cancer. And it is recommended for boys and girls. Yes, I know boys do not have a cervix, but HPV strains can cause oral, anal, or penile cancer in men when they grow up. When HPV was first introduced, 3 doses were recommended. The second dose to be administered 1 to 2 months after the first dose, and the third dose to be administered 6 months after the first dose. In 2016, after reviewing data from several studies around the world, experts agreed that 2 doses given 6 months apart were just effective as 3 doses, but only if initiated in younger adolescents 9 to 14 years of age. If initiated after 15 years of age, then the 3-dose regimen is still required. This is because research has shown that HPV vaccine elicits a higher immune response in younger adolescents than compared to older teens. Right now, there are several studies in the world, in Uganda, Costa Rica, and India, to determine if one dose is just as effective. Why is the number of doses important? The number of doses is key in vaccine uptake worldwide, for which I mean adoption or usage, as it translates into larger savings in time and resources. Since its introduction, HPV vaccination has been rolled out in many high-income countries, but progress is slower in low to middle-income countries because of resource constraints. The countries in green on this map have already introduced and incorporated HPV vaccines into their national immunization programs. Countries that have not yet adopted HPV vaccines, shown on the map as gray, can apply for support to fund national introductions from Gavi, the Global Vaccine Alliance, whose video we saw earlier. Gavi added HPV vaccines to their portfolio in 2012 with an aim to vaccinate over 30 million girls in 40 countries by 2020. So far, Gavi has helped 30 countries to conduct HPV vaccine demonstration programs, which is the first step towards national introduction. 6 countries so far have introduced the vaccine into their national immunization programs. Like I said earlier, there are challenges with HPV vaccine uptake around the world. As shown here, challenges fall into 3 categories: economic, structural, and socio-cultural. I'm going to discuss these challenges in a little more detail. Economic challenges. HPV vaccines can cost almost $100 in high-income countries. In the US, the cost of these vaccines is covered by insurance with nominal out-of-pocket expenses, if any. For low to middle income countries, the lowest public sector price is about $13 per dose. This is still a huge economic burden on countries, and it really hinders the likelihood of adopting HPV vaccines into their national immunization programs. But there's good news. Thanks to Gavi, the Vaccine Alliance, the lowest income countries now have access to HPV vaccines for as little as $4.50 per dose. In addition, WHO's decision to switch from a recommended 3 schedule to 2 dose schedule has really helped to facilitate country rollouts and further reduce costs. Structural challenges. The next few slides focus on structural challenges, most of which are not issues in the developed world. And these issues are not solely attributable to HPV vaccines, but to all vaccines. Vaccines only work when supply chains work. Improving the immunization supply chain, the network of staff, equipment, vehicles, and data needed to get vaccines from the manufacturer to health clinics plays a critical role in strengthening immunization programs. This is a cumbersome process, but Gavi helps set up and establishes these networks for member countries. Vaccines work when they are available. Too often they are not. Many countries report running out of a vaccine for at least a month or so. This is mainly due to paper handwritten registers with no data sharing procedures and ad hoc stock replenishment. transition to a simple but efficient tracking system using any kind of communication device, from a desktop computer to a tablet to an old-fashioned flip phone, and just about any operating system with a wireless connection, has made a huge difference. This system was first piloted in Uttar Pradesh, India, where stockouts were common and hindered vaccination programs. With more reliable data flow, health workers maintained a more consistent supply of vaccines, which led to an increase in immunized children. In 2016, this pilot project transitioned from 41 clinics to 27,000 clinics in 12 of India's 29 states, providing decision makers with a more stable data management system for their immunization programs. Vaccines have to be delivered wherever there is need, no matter how remote the location. If a vaccine is exposed to heat, it is no longer potent. Cold chain, which is a temperature-controlled supply chain, strives to maintain a storage temperature between 2 and 8 degrees Celsius. Again, Gavi helps member countries with training and implementing these practices. This is a picture of healthcare workers transporting vaccines to a remote island in Tanzania using a cold storage box. Vaccines work best when delivered at the right temperature, cold but not freezing, and never warm or hot. Accidental freezing is pretty common and occurs in 1/3 of countries, regardless of their income. As mentioned before, during transportation from manufacturers to more remote areas in the world, vaccines are constantly at risk of being exposed to too much heat, sapping their potency. Too often in the past, heat-exposed vaccines were used because the problem wasn't recognized. Or health workers tossed out viable vaccines because they suspected damage from overheating. Pap found a technology originally used by the food industry to monitor perishable products and worked with its owners to adapt it for vaccines. The vaccine vial monitor is a small circle sticker that is placed or printed on a vaccine vial. The sticker changes color as it is exposed to heat and therefore provides a visual indication whether the vaccine has been stored at an ideal temperature and if it is still potent. The white square that you see in the purple dot starts to change color to gray to black as it's exposed to heat. I have a prototype of it over here in case you'd like to come and look at it afterwards. Today, the WHO requires that all vaccines purchased through the United Nations Children's Fund, UNICEF, uses vaccine vial monitors. In the years since its introduction, vaccine vial monitors have demonstrated their value over and over again. In a recent example, when electricity went out at a health facility in Indonesia for several days after an earthquake, vaccine vial monitors showed that most of the vaccines were undamaged despite the heat, saving 50,000 doses of vaccines that would have otherwise been thrown out. Socio-cultural challenges. Vaccines are safe and undergo many years of testing, but despite that, vaccine hesitancy exists. HPV vaccines have strong safety records. Most common reported adverse events for HPV vaccines are pain and swelling at the injection site, but this is the case for any vaccine. Most concerns surrounding safety in both developed and developing world are usually alleviated once the parent or patient is properly informed. Vaccine coverage is hindered by the fact that HPV is a sexually transmitted disease. As a result, parents around the world claim that HPV vaccines infringe upon their right to discuss sex on their own terms, and some believe it promotes teenage promiscuity. None of these claims have been proven to be true, and again, education is key in overcoming this barrier. Lack or limited knowledge about HPV and HPV vaccine has led to low vaccination rates. In the US, HPV vaccination rates lag behind other routine immunizations. And we think this is mostly attributed to doubts on whether to vaccinate boys, as the value in protecting boys is less clear. As I said earlier, progression of HPV infection in boys can cause penile and anal cancer, to name a few. Therefore, in developed countries, HPV vaccines are recommended for all adolescents, boys and girls. However, in developing countries, cost-effectiveness studies have shown that it is not cost-effective to target boys, and thus the emphasis is on adolescent girls. Non-completion of doses is common. This is either because individuals are unaware of their risk of being infected with HPV, or they're unaware of the HPV dosing schedule and forget that a second or third dose is needed. In developing countries, people sometimes travel great distances to a clinic for a vaccination, so chances to miss doses are even more common. As a result, many HPV vaccine campaigns in developing countries occur in schools. Bottom line, education is key in overcoming these challenges. Like I mentioned earlier, researchers are currently studying whether a single dose is enough to elicit an adequate immune response and are estimating the length of that immunity. One dose will certainly resolve the issue of non-completion, but does that mean that immunity will only last 10 years? Will a second dose still be needed? And if so, is the current 2-dose regimen the best solution? These are questions that the current ongoing studies are hoping to answer. Certain religions and belief systems promote alternative perspectives towards vaccination. Religious objections to vaccines are generally based on ethical dilemmas associated with using human tissue cells to create vaccines, and the belief that the body is sacred, should not receive certain chemicals, blood, or tissues from animals, and if sick, should be healed by God or other natural means. Philosophical beliefs, popularly known as the anti-vaccination movement, is based on a number of theories. These individuals are highly suspicious of vaccine manufacturers and researchers who encourage vaccinations. They claim vaccines are not safe. It's all about profitable gain. Vaccine preservatives are toxins, and the dosing schedules are too much for a child's immune system to handle. Again, education is key. Even though all the anti-vaxxers' claims have been debunked, the anti-vaccination movement, which is solely prominent in developed countries, continues. In the US, only 3 states, California, West Virginia, and Mississippi, do not allow for any religious or philosophical exemptions to vaccinations. Nowadays, for religious exemptions, many states require parents to list and certify membership with a religious community. And for some philosophical exemptions, parents and patients must now consult with a healthcare provider so that accurate information of the benefits and risk of not vaccinating can be provided. But what about beliefs and perceptions in developing countries. In reality, most people have had firsthand experience, accounts of debilitation and death from diseases surrounding them. So in developing countries, benefits clearly outweigh the risks. Aisha, pictured here with her father, was one of the first girls in Africa to receive the HPV vaccine. Immediately after vaccination, Aisha was wiping tears from her face. It wasn't the shot that upset her. She was crying because her mother died from the very disease she was being protected from, cervical cancer. Since HPV vaccines is a rather recent development, and many women in the world did not receive it, they cannot reap the benefits of the vaccine. Moreover, HPV vaccines do not protect against all high-risk HPV types. So to tackle cervical cancer effectively, screening programs have a vital role in prevention, allowing for early detection and treatment. I'm now going to focus on screening for cervical cancer. The most common screening for cervical cancer is a Pap smear. A Pap smear is a diagnostic test. Women undergo a pelvic examination where cells are scraped from the cervix, smeared on a slide, and then examined under a microscope to check for disease or abnormalities. If any abnormalities are seen, women are told to come back for another pelvic exam where a biopsy of the tissue is taken for further analysis. Pap smears are only 60% effective in diagnosing disease. Again, there are several barriers to getting a Pap smear. As in the case of vaccine, there are economic, structural, and socio-cultural. I'm not going to explain each and every one. In developed countries, we do not have the economic or structural barriers, and Pap smear screening is widespread. As a result, we've seen a huge decline in cervical cancer deaths, even though there are still some pockets of women who do not get screened. Women from ethnic minorities, people living in remote areas, and women with lower socioeconomic status. However, Pap screening in developing countries has not had the same success, and it's mainly due to the structural and economic barriers. The success of Pap smear depends on repeat testing and high-quality laboratories, which in turn drives up cost. A private space is needed with clean tools to perform a pelvic exam. Additionally, there are very few trained personnel who can adequately read cytology slides, thus leading to a really long wait time for receiving test results, sometimes 1 to 3 months. This makes it very difficult to find the woman to come back in case she has any abnormalities. So, what options are there in the developing world? In the 1990s, visual inspection with acetic acid, also called VIA, was introduced as an alternative to Pap. This is a simple procedure where a 3 to 5% solution of acetic acid is applied to the cervix and inspected a minute later for aceto-white appearance. VIA is just as good as a Pap in detecting cervical cancer, and it is recommended by the WHO, especially in areas with limited resources. It involves a 5-day training curriculum for nurses and midwives and requires minimal supplies and equipment. The greatest advantage is that it provides immediate results. If positive, providers can treat immediately with cryotherapy or thermal ablation and take a biopsy to confirm their diagnosis at the same time. This is a great comprehensive screen and treat strategy that can be provided in a single visit. However, VIA has its limitations. Its power to detect varies greatly between 60 and 80%, and it really depends on the skill of the provider. But there is a new screening method for cervical cancer, HPV DNA tests. These are highly sensitive, about 80 to 90% effective in detecting HPV infection. The HC2 test is a sophisticated hospital-based test. This test was only developed and available in well-resourced settings. It is costly. In 2013, PATH partnered with the manufacturer of HC2 to create an easier-to-use and less expensive test, primarily aimed for low to middle-income countries. The result was the CARE-HPV test, shown here on the right. CARE-HPV is a simplified, robust, and affordable HPV test that can be used in low-resource settings. The test can be run in any room, does not need running water, air conditioning, and the process is simple and can be conducted with people with limited laboratory training. CARE-HPV is a batch test. 90 samples can be run per batch. The test run time is 3.5 hours per batch, and the test costs about $5 per test. The biggest asset of CARE-HPV is that it allows for women to collect their own vaginal sample without a pelvic exam. Here I have two components of the test, a soft brush to collect the sample and the container with buffer medium to transport the sample to the lab. PAT tested CARE-HPV in India, Nicaragua, and Uganda. We enrolled over 20,000 women in our research study and screened them with 4 screening methods: PAP, VIA, a self-collected vaginal CARE-HPV sample, and a provider-collected cervical CARE-HPV sample. This is what we found. CARE-HPV performed better than Pap smears in that it was better at detecting disease. It was very feasible to run. Self-collected samples from the vagina were just as good as provider-collected samples from the cervix. Women loved the self-sampling option. The cost of detection and treatment is just as good, if not better, than Pap smears, and it was very cost-effective when run in batches. So, allowing women to collect their own samples for HPV test makes screening for cervical cancer accessible almost anywhere. This is a potential lifesaver, especially where there are logistic limitations. Again, no need for a Pap smear, pelvic exam, or speculum. Just a swipe with a small and soft brush, and you're done with screening. So what's next? PATH is currently providing technical assistance to ministries of health in Central America to introduce and quickly scale up HPV testing for cervical cancer screenings into their public health programs. Self-sampling is the primary screening modality. Data from PATH's Scale-Up project recently showed that over 200,000 HPV DNA tests have been carried out. Success has been a result of receptive governments, enthusiastic healthcare workers, and the fact that self-sampling is in demand. And lastly, in May last year, the WHO Director General made a call to eliminate cervical cancer. As shown in my presentation today, we know what works and we know how to prevent and control this disease. To summarize, the 3 key targets towards achieving the elimination of cervical cancer include increasing coverage of vaccination against HPV, increasing screening coverage with an HPV test, And lastly, appropriate management of women who have screened positive in order to reduce mortality from cervical cancer. Thank you for listening. I'll now take questions.